Hi everyone. So today I'm going to be covering a few endocrine questions for the MRCP Part 1. Please let me know in the comment section if you liked it, and I'm happy to make more questions for the other specialties as well. So let's jump straight in. Question 1. A 42-year-old lady was admitted to the acute medical unit with 1-week history of abdominal pain and constipation. Her blood results are shown below. I'll give you a second to have a look at the bloods. So as you can see, she's got a high adjusted calcium, she's got a high parathyroid hormone level, and they ask, what is the most appropriate step to manage this patient? So have a second to look through the different options. All right, so the correct answer for this question is refer for parathyroid surgery. And let's go through the reason for that. So if you look at the blood test, they've got a high adjusted calcium, they've got a high parathyroid hormone, which makes us come to the conclusion that the patient's got primary hyperparathyroidism. And if we look at the different options, so option A, commence IV fluid rehydration. So it would be a good option if it was the initial step. However, the question clearly asks for the most appropriate step, and in this case it would be surgery. Therefore, IV fluid rehydration wouldn't be a good option. Commence cinacalcet, so it's a calcimimetic drug which could be used in secondary hyperparathyroidism generally in patients who have CKD, and could also be used in primary hyperparathyroidism if the patient is not a surgical candidate. And then looking at option D, complete myeloma screening. So it's good thought in a patient with hypercalcemia, but the age group, the patient is 42. It's very unlikely to see myeloma in that age group. Generally, you tend to see it in patients who are in their 70s or 80s. And option E, don't do anything currently, recheck calcium and PTH in 4 weeks. That just would not be a very good option. So in terms of indications for referral for parathyroid surgery, let's go through them one by one. So first one would be symptoms of hypercalcemia, and those would be things like thirst, polyuria, commonly, and adjusted calcium more than 2.85, and also if you have end organ disease. And what they mean by that is if they've got renal stones, fragility fractures, excellent. So that is question 1. Let's move on to question 2. A 32-year-old lady is reviewed by her GP due to complaints of a swelling around her neck. On examination, the GP is able to palpate a hard anterior mass, which he suspects could be a thyroid cancer. Which of the following type of cancer in this patient is this patient most likely to have? So the different options. I'll give you a second to have a look and come to an answer. So the correct answer in this case is papillary carcinoma, and the reason for that is if you look at the age group, the patient is 32, and the most common type of thyroid cancer in that age group is papillary carcinoma, and it's the most common type of thyroid cancer generally speaking. And obviously you've got other types of cancers like follicular carcinoma and anaplastic carcinoma, which are less common. So I would say about 70% are papillary carcinoma, 20% follicular carcinoma, and anaplastic is generally about 10%. Lymphomas generally tend to be very, very rare. And option E, the Quervain's thyroiditis, so would not present like this. There would normally be a history of a painful goiter or a preceding viral illness. So the story doesn't really match with the Quavian thyroiditis. Also, they ask what type of cancer, and obviously the Quavians is more of an inflammatory condition rather than a cancer. Uh, in terms of which one of the following is the most aggressive type of cancer, then that would be anaplastic carcinoma, which you generally tend to see in a slightly older population, and you get a more aggressive nature of disease, tends to invade faster. Uh, so yeah, that's question 2, and let's move on to question 3. A 32-year-old lady is diagnosed with prolactinoma, and the endocrine consultant has commenced her on carbapenem. What is the method of action of this drug? So I'll give you a second to have a look at the options. So in terms of the correct answer, it is D, dopamine receptor agonist. And what you need to remember is dopamine inhibits secretion of prolactin. And basically, when you want to reduce the secretion of prolactin, you want a dopamine receptor agonist like cabergoline, which is the same reason why you don't want to prescribe such patients metoclopramide, as metoclopramide is a dopamine receptor antagonist. In terms of the other options, we've got the serotonin reuptake inhibitor. Those would be the SSRIs like sertraline, citalopram, etc. Beta 2 agonists, example would be salbutamol, which is commonly used in asthma. Option C, alpha blocker, so doxazosin, which is an antihypertensive, and tamsulosin is alpha blocker as well. The last option, selective growth hormone receptor antagonist. An example of that would be pegvisomant, which is sometimes used in the case of acromegaly when surgery is not suitable. So yeah, option D is the correct answer for this question. Let's move on to question 4. A 42-year-old man visits his GP after he was recently diagnosed with type 2 diabetes and commenced on metformin 2 weeks ago. His HbA1c was found to be 62. He reports having some abdominal discomfort and diarrhea and would like to know if his medication could be changed. What is the most appropriate next step? Alright, so the correct answer is option A, commence metformin modified release formulation. So it's a very common question that comes up in the MRCP. I think generally speaking, you would think, okay, metformin's not working, maybe we should try a different type of anti-diabetic, but generally the modified release formulation tends to have fewer GI side effects, and that would be the next step before moving on to the other options. So if you look at option B, commence glycoside, so I'm sure you guys know what the method of action is and what type of drug it is. So glycoside is sulfonyl urea. It's really good to know the method of action of all these drugs and the different side effects. And basically, sulfonyl urea increase the insulin secretion, and side effects are weight gain and hypoglycemia. These are the common ones. So some questions might involve a lorry driver maybe, and you should always know that the glycoside, which is a sulfonylurea, which would not be a good option because of the risk of hypoglycemia in case that happens when they're on the wheel. And then looking at option C, reassure patient and don't make any changes, that just would not be very appropriate. Option D, commence pioglitazone, so that is thiazolidine dione, which is quite a good anti-diabetic medication, however not the correct answer, and basically they work by working on the PPAR gamma receptors. And in terms of contraindications, it causes fluid overload, so not in cases of fluid overload, so in severe CKD and heart failure, and also it increases the risk of TCC bladder, so transitional cell carcinoma in the bladder. And then you've got the last option, which is empagliflozin, that is an SGLT2 inhibitor. It's a great drug which is especially useful in patients with heart failure and also CKD. Important things to remember with this medication is that it can unfortunately cause euglycemic DKA, and you should always warn patients to hold this medication, say if they're going through an acute phase of illness, if they're having an infection. So there would definitely be a question on anti-diabetic meds in the MRCP part 1, so it's quite good to have a thorough read of the different medication and the method of action and side effects as well. So final question, what is the most common cause of primary hyperaldosteronism? Give you a second to look at the options. So the correct answer in this case is bilateral idiopathic adrenal hyperplasia. It's just a fact that you need to remember. So it can come up in the exam, and also the other thing to remember is primary hyperparathyroidism. You should know is commonly caused by parathyroid adenoma. It's important to not get confused with the two. And if you look at all the other options, they are all causes of hyperaldosteronism, but in this case, obviously, they're asking for the most common cause, and that would be option E, which is bilateral idiopathic adrenal hyperplasia. Excellent. So I hope that was of some use. And as I mentioned earlier, please let me know if you want me to go through more questions, and I'm very happy to do so. Thank you.